for sharing your story earlier. I'm always inspired by it. So I was born and raised in San Jose, California. I was the son of immigrants. My folks immigrated from Syria and Pakistan. And, my grandmother was recently displaced in the Syrian civil war, well, now about, 9, 10 years ago. And so I was a medical student at the time, and I realized that a lot of folks around the world, and even in our own country, are getting really fragmented care because, even the amazing physicians and nurses and allied health professionals that are trying to take care of them are not really getting the whole story. So I ended up founding an organization, Hikma Health, which is actually how Cecilia and I first connected. It was a tech nonprofit, and Care Message was one of the OG tech nonprofits. So we learned a lot from watching their arc, and proud to share that at Hikma Health, where I'm now the board chair, we've served about 1.3 million patients around the world in 25 countries with a free and open source EHR. So that was really what opened my eyes to the impact that we can make through these technology solutions that empower clinicians to deliver the very best care that they can. And I was, shadowing in about 2019 on the obstetric wards at Mass General Hospital when we had a patient come in at 4 a.m. experiencing a stillbirth. And I realized that, we really let this mom down. We had to tell her that night that, we were trying to record the fetal heart rate and look for it. And we had to tell her that we'd lost the baby. And I realized that, fundamentally in obstetrics, more than perhaps anywhere else in medicine, we were being reactive. We were just assuming that things were going to go well and the mom was going to be healthy, baby was going to be healthy. And then something happened. Oh no, please come into the ED, come into triage. We'll try to take care of it. Suddenly you have gestational diabetes. You were diagnosed at, 28 weeks, and now there's not a lot of recourse. And that actually happened to my own wife, who is an OBGYN herself, who was borderline gestational diabetes. Our son was diagnosed IUGR. And we were two very privileged physicians living just 10 minutes from Mayo Clinic at the time. But if even for us, we had these anxiety-riddled drives at 11 p.m. to the emergency department, we were thinking, well, how must this be for some of the patients we serve in South Texas who are struggling to make ends meet, have 4 children at home, and on top of that are having this uncertainty and anxiety about how is my pregnancy going? Is my next baby going to be okay? Am I going to be okay? So we created Delfina basically as a solution for both the providers who are typically on the front lines at a federally qualified health center, at a safety net hospital, trying to care for these Black and brown patients who are bearing the brunt of the maternal health crisis in this country, for them and for their patients to deepen that connection and that trust to be able to take proactive care and get ahead of those complications before they even happen.
Yeah, incredible story, and I think it shocks us, but it maybe in some ways shouldn't shock us when we see some of the data around, our maternal our disparities, but it can happen to anybody, and that's the reality of it. I had a friend who delivered a baby, the last 2 weeks, and last week ended up in the hospital with preeclampsia complications, and it's just you don't expect it. It comes out of the blue, and she's a physician as well, so and I felt powerless remotely as a friend, even just knowing like what can I do, from afar. So these are all difficult situations for patients to go through, and so many solutions that I think are necessary to really change that trajectory and what those outcomes can really be.
Appreciate it,
Um,
absolutely. I think you said it, for us, it's like you would think that for a physician, things are going to go smoothly, but the reality is we're getting, whether at Mayo Clinic or Hope Clinic, our partner in Houston, who does an amazing job delivering proactive care, even prior to Delfina, they have been delivering their own babies, and as many of the folks on this call may know, the trend has been towards actually having the deliveries be done by OB hospitalists. Not that there's anything wrong with that, but that's been the trend towards subspecialization and kind of mechanization of medicine. And Hope Clinic said, no, look, we're going to do this ourselves. But wherever you're getting the care, it's like the commitment that you have in your heart and your mind to care for this patient doesn't play out in execution, and you end up with a patient at 11 p.m. coming to the ED, whether that's the University of Texas ED or the Mayo Clinic ED, whether your patient is a mom with 4 kids on Medicaid who is, currently in school, or it's my wife who is an OBGYN physician. And so in some ways, and reading, in particular, the Williams story, she was, Serena Williams was going through this and, has been very public about her story. She's a very wealthy woman and could not be insulated from the implicit biases of our healthcare system that still impacted her, and she nearly passed from a PE, um, a pulmonary embolus, a clot that can be, really life threatening for a woman peripartum. And so that story just really shook us all awake, I think, as clinicians, that like this implicit bias was part of my medical education too. I also looked at
Mhm.
a bunch of, pictures in dermatology that were all white skin. And finally things have started to change. But even ACOG, American College of Obstetrics and Gyne, they still have racialized medical calculators on their website. At least they now put a disclaimer saying, please note that race is a proxy for genetics and environmental biases encountered, et cetera. But in the end, it's still, if you're talking to a black patient telling her you're supposed to take aspirin because you're black, that is not what we should be doing, and it's not going to fly with our patients in 2026, nor should it. So I think that's, in some realizing that like how bad the care can be and how horrific the experience can be. But let's be real, at a population level, the brunt is still borne by certain folks, and we need to bring that level up and close the gaps for everybody.
Yeah, definitely. And I know you mentioned Hope Clinic, who happens to also be a Care Message customer, and we share a few others like Legacy Community Health Center too in Houston. I was curious if you could share maybe one of your maybe most memorable stories that you've had, either working with one of the clinics, or to the extent that you can, obviously patient, maybe privacy reasons. We can keep it generic, but a memorable story you've had with a clinic or with a patient that's really changed or challenged the way that you think about maternal health.
Yeah, I would say the story that has like fundamentally changed everything for me, because before that, Delfina was, an idea born in a lab, a software system that was built, and we had folks working on it, and we kind of saw early signal that like this was going to work. But the moment where it changed for me and became like my life's mission, that like I feel an obligation and almost a compulsion to just get this out to every single obstetrician and CNM in the world to take care of her patients, was a case we had in Houston in about early 24. Dr. Cynthia Rios, she's actually sharing it as a de-identified case in a publication. So she was using Delfina's platform and saw that one of her patients was high risk for hypertensive disorders of pregnancy. That patient would not have met ACOG criteria. She would have been considered low risk.
Mhm.
She was a 25-year-old Latina mom, no, risk factors that would have checked the ACOG boxes. So because Rios had her in Delfina care, she got her the blood pressure cuff. She got her in the high risk workflow where she was checking in on her more frequently. And then her blood pressures started trending up. She started having systolic blood pressures in the 130s, which is, not an emergency, but on her baseline high risk that Delfina had identified, that is concerning and was cause for her to say, okay, I need you to come in tomorrow and we're going to look at you and we're going to talk about this. So while she's there, she does the exam. She ends up, taking labs, sees that there's protein in her urine, which is the kind of canary in the coal mine for preeclampsia. And so she
Mhm.
ends up inducing and delivering the baby at 31 weeks. We weren't entirely sure what to make of that whole story, Cecilia, because you never really know the counterfactual, right? We don't know if the patient would
Mhm.
have shown up, would have delivered healthy. We never really know that in medicine. And the neonatologist ended up actually calling Rios, who called us and said, without Delfina care, this most surely would have passed. And if this baby
Wow.
had made it, it would have had very severe neurologic and other developmental challenges, if you had waited for the 32-week visit, which would have otherwise been standard. So to us, and they're now writing up this case together, the OB and the neonatologist, and to us, this was sort of like the first N=1 signal that like Delfina's approach in partnership with our clinical partners is life-saving. That when we can get the patient oriented and aligned to understanding her own risk and be empowered to take action, in partnership with a clinician, it can truly have life-saving impact. And so when we look at the 800 to 1,000 maternal deaths every year, whether they're hypertensive and cardiovascular, whether they're mental health related, in the end, the same paradigm applies, that if we can just get the right kind of support to that patient at the right time without burdening the clinician, but empowering her to take that level of better care for more patients through automation, we can get ahead of this and we can solve this crisis.
Yeah, I very powerful story, and I love the approach you all take, specifically of working in partnership with the clinical team. You're not replacing that clinician, you're providing, you're offering augments what that organization can do, on their own. And I was wondering if you could share, more of that with the audience in terms of what the Delfina platform offers, sort of what the offering is, how that works hand in hand with the clinical staff at the health center.
Yeah, so I mean, we learned a lot from you actually. I think like seeing how Care Message has augmented a lot of the core clinical operation. It's not disruptive, but it's empowering the clinic to do the things to get the patient to actually then do the things that we know relate to better outcomes. And so fundamentally, the paradigm with Delphina is, have the patient be following the care plan that's set by the provider with very close adherence and support. So, as an example, if Miss Jones, one of your patients, is high risk for hypertensive disorders, and Miss Sanchez is high risk for gestational diabetes, they should be following different workflows and adhering to them closely. My wife is actually currently 7 months pregnant, and she's using the Delphina platform, and she has been, very closely day after day doing the tasks, the glucometry, the weight measurement, the exercise and diet, and I'm really grateful to share. To date, she's been very healthy, and so to see this play out on the patient side has been really motivating and inspiring and gratifying because as a patient, going through pregnancy and postpartum, there's a lot on your plate, there's a lot on your shoulders.
Mhm.
And to have a system of care that's backing you up, supporting you every little step of the way, and you're not having this moment when you're going to your next OB visit being like, oh yeah, did she say that I was supposed to take aspirin, was supposed to measure my BPs? And like, even if you were doing it, maybe you were doing it half the time, maybe you wrote your BPs on a scroll of paper. Another clinician I last week literally told me it was on a paper towel. He drew the glucose log on a paper towel, and the patient like took that paper towel and tried to write on it and like tried to bring it back, which is just like that. That shows you how motivated our patients are. They do want to do the right things, but it's on us as the care system to empower them and support them. So with Delphina Care, our colleagues that we both work with at Hope Clinic or Legacy, they're looking at a portal it can be embedded in, Athena, eClinicalWorks, Epic, and that portal is showing them, patient by patient across their pregnancy panel, who's at high risk complications and what workflows are being activated to support them. Now, those workflows can be activated manually with one click, or, shout out to our colleagues at Hope Clinic who were like one of the first to implement the automated clinical workflows, where within safe bounds, these workflows are just happening. Like the patient is getting a blood pressure cuff, the patient is getting on a dietetics referral to do the 20-gram carb diet without the provider even having to click. So that actually shifted the paradigm from, okay, how much are clinicians and patients really engaging with this click, 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 to like how much
Mhm.
clinical action happening. And on the patient side, they're deeply engaged. The average patient is engaging about 12 times a month with our app. And if you have a higher risk patient, that's like 30 plus times. Your patient is supposed to be doing something daily. In Delphina Care, they're actually doing it and you know that they're doing it. And on the provider side, you don't have to be logging in, monitoring, checking every little thing. You see her for the next prenatal visit, she'll actually be prepared. You'll know that she's adhered or hasn't, and you can have a very informed conversation about why that is. So it just really up levels the efficiency of running an outcomes focused clinical operation, which all of the colleagues on this call are running. And I'd say, the real for us, the real challenge of Delfino is that we also know that our FQ partners don't have the kind of funding to be able to do this. So we actually went out
Mhm.
and set up health plan funding, health plan relationships, where our relationship with our FQHC partners is not a paid relationship. They don't pay us, we don't pay them. It's a true partnership where we are helping take care of these patients and make sure that they adhere to the workflows that matter. But we're getting funding separately from the health plans on the basis of our ability to improve the population health outcome.
Yeah, it's incredible. And I one thing that I love from what you mentioned is the just the acknowledgement of how much patients want to do this too. Like patients are they welcome the support, they want to do the work. And I think for me in some of the early years of Care Message, some of the struggles I had was hearing, other parts of healthcare call this patient population, non-compliant, or it's just they attribute certain things that almost create a limited mindset, not a growth mindset on who this population is or who they can be. And a lot of times it's a lack of resources, or it's a lack of actionable, information and education that can, make a big difference. And they are more than willing to be supportive and adopt these solutions when they're truly tailored to what they need, and tailoring that to their needs and work hand in hand with what they expect from their care providers.
It's so true. I mean, I think we see this especially in pregnancy, but I think to your point, even in my wife used to run a clinic in Tampa where it was mostly chronic care, and these folks were generally 60 plus and entirely immigrant community. And to your point, Cecilia, even some of the staff that would like volunteer their time there, we've all been kind of inculcated in this like perception of like, oh yeah, non-compliant, like challenging population, and people code it in different ways in their language, but the reality is it's demotivating to the therapeutic partnership between the patient and the clinician because like going into the room, the patient has been let down time and time again by the doctor, and the doctor is just like, well, this is probably not going to be the best use of my time, and I already have to go write this note on this other patient. So that like it leads to, most importantly, the patient's continued loss of trust, but it also contributes to clinician and burnout and inefficiency. And so what I think we've done really well is to, while continuing to center that therapeutic relationship, we have offloaded a lot of the work that the clinicians really don't want to do to let them really focus on the original reason they got into medicine, they got into obstetrics, which is the patient in front of them. And we've given both parties total clarity. So, for example, they're not
Mhm.
having an awkward conversation about why you have to take aspirin because I'm Black. It's Ms. Jones, here are your risk factors. Here's this algorithm we use that has looking at all your risk in totality as a full human being, your clinical and social risk. And here are the three factors that pop out. This is why you taking this pill every day is going to help you be healthier. And yeah, our pregnant patients are incredibly motivated. They really want to do whatever it takes to be healthy. And we have folks with
Mhm.
we have folks with a lot of history of alcohol or other substances, and this is the time, this is where they're going to do what it takes, they're going to seek the resources, and it's then incumbent on us to reach out our hand and make sure we get them to the Suboxone clinic, we get them to the recovery services, we get them wherever they need to be. So our approach at Delfina has always been as you are, and we know that you have had a lot of letdown and moral injury by the healthcare system. We're not going to fix it all in a day, but our commitment to you is that we understand it's our responsibility as the clinicians, as the technology. We have to build for you and we have to serve for you in a way that meets you where you truly are. And yeah, I worked with some of these patients myself at the East Boston clinic. I worked with them at, Boston Healthcare for the Homeless. And, I'll never forget seeing patients who like, yeah, they told me these stories catastrophically let down. In some cases, they had lost family members because of the implicit bias. And they're like, "What do you want me to do? You want me to come in and engage with the system?" So their non-compliance, from the medical perspective, is self-protective. And I think what you all have done, and what I think a lot of the FQ partners on here have done, is lay a foundation for like when you have the right technology that enables you to be on the same page about what is going on with your patient, you do have that trust. And without you, we couldn't do that, right? If we're just like a random tech platform, like yet another app for pregnancy, they don't really trust that. But they trust Hope, right? They had their first baby at Hope. Dr. Lalani showed up at midnight, delivered their baby. So that trust is built over decades, and we inherit that, and we're really grateful for that in our partnership. So we are committed to that and building on that and making sure that, like, yeah, with the clarity that comes with Delfina, there comes that responsibility to continue to deepen that trust. That we're not just giving you insight about what's going to happen, and then oh, oops. We make sure that we support you and the clinician so that the things happen that you actually have a better outcome.
Yeah, and I'd say trust is probably one of those. I call it one of the hallmarks of community health centers, and just a lot of these safety net clinics. They've earned their role in their communities through building that trust and just showing up continuously. They don't parachute in and try to do a quick and done, sort of solution. They've been in this work, and a lot of health center staff, I love when I talk to them, and they've been at that health center for 10 years because they're committed to their community and making those improvements, and they've built that trust with blood, sweat, and tears. And so I'm curious how you continue to think about how you blend that trust, like building that trust, the human touch that the staff at Delphine are providing to the patients with the technology, like blending those two together.
Yeah, it's interesting you mentioned that, Cecilia, because just last week I was visiting with a clinic in lifelong health in Oakland. And a lot of these FQ partners, like these folks are not just like, it's not like the clinic popped up and then was staffed by the community. It was born of the community. The community created it because the traditional healthcare system was not paying attention, was completely letting them down. There's actually an amazing podcast, by the way, about the role of the Black Panthers in sickle cell specifically. Highly recommend to anyone on this call. And so I was with John Jenkins, who's the CEO of Lifelong, and he was showing me the clinic and telling me kind of all about the history. And I was thinking about this a lot because I'm not from the Black community. I'm not from Oakland. I grew up, 45 minutes away in San Jose. So how do I deserve and earn the trust of the mostly Black patients who are in that community and being served by, well, a diverse staff, but a lot of Black clinicians who, they went to medical school or nursing school to specifically come back and serve the community in which they're born, which I'm so inspired by. But how do I, as not a member of the community, earn and deserve that trust? And so I think it starts with humility and listening. Like I talk a lot. I come on panels with you and I talk, but when I'm in those spaces, I really try to listen and understand whether I'm talking to, a leader in the organization, an individual clinician, a patient. I love shadowing. That's what gives me the most joy. Whether or not Delfina is in action yet is to like see and imagine where it will be and where we'll make that impact. And then after it's been deployed, to round with the clinicians and see, well, what impact is it having on your practice? And that's what I'm doing up here now in Minnesota. So I'd say like for us, and I would say like Cecilia, you probably are in a similar situation in some communities. Of course, you're of the community, but when you're at a certain FQ, if you went to lifelong, it'd be the same, right? It's like how can you serve that community? But I think just starting with the humility that like, yeah, some when you and I are in there, the people who've been there for 30 years and literally might have been patients at that community, might have been delivered by an OB when they were a baby themselves there, learn from them. And yeah, we have the cool technology, we have the AI, we have a system, it works, we have the data, humble ourselves and come in and say, if we want this to work here, if we want it to work at lifelong, we need to read and understand and listen and see how these workflows can adapt so we can be partners in overcoming the systemic racism that these groups have been fighting for 60 years.
Yeah, no, I that resonates with me deeply because, I share some identities with the populations that Care Message serves, but we serve other communities where I don't, for example, my family, we have, indigenous ancestry, but through colonization, we are completely detached from, what that was. It creeps up sometimes, in the foods we eat. And when I hear stories from my grandma, from the crops, their crops, they were farmers, were the three sisters. That's what they planted, was corn and calabaza squash and beans, and like the whole process is it's carried through and it's made it through generations. But we don't have the language, we don't have some of the other aspects of it. And so for some of the work we do with tribal health organizations, I step into those spaces to listen and really learn and try to see how we can come at that work from that place of learning and understanding, and surfacing the power of what the communities already made. Because before any of our technologies came around, these communities had already figured out solutions that were working. And sometimes the technology can just come elevate those things, but it's not going to replace or be better than anything that a community member with lived experience would, bring to the table. And so it's definitely for me been a learning journey for the various populations Care Message serves. In some areas I can identify, and others I'm a learner on this journey as well, and figuring out and learning from community members to see how our technology and our products can continue to evolve to support their work. But it's ultimately something communities have already, figured out, that sometimes just might need the technology to give it a boost, but it's not going to replace at all what can be like community created.
Yeah, absolutely. And I'm curious to hear in your work with tribal communities. We're just getting started. We work with a lot of folks in New Mexico, and there's an amazing Native midwife-led practice. It's called Changing Woman Initiative. And they, I think they're largely led by Diné Navajo folks, but they get folks from all over Albuquerque, from all kinds they get folks from Pueblos coming down to have that experience because, I mean, they have revived a lot of the cultural traditions around Native midwifery. And I spent a year living in Ayacucho in Peru, and I learned from the curanderos. I met a partera who knew how to do external cephalic version, a technique that was discovered by a European physician in the 1960s, and they've been practicing it since Inca times. It was impressive. She was like in her 80s, Cecilia, and she was external cephalic version takes a lot of force, and I was like, she's got it. And so when we think about particularly Native communities, I think, for example, in maternal health, the Black maternal health crisis deserves and gets a lot of attention in the New York Times. The Native maternal health crisis is really underappreciated, understudied. Shout out to some of the folks here in Minnesota. Dr. Koza Manel has written some great papers on kind of the problem space. and the folks at Choctaw Nation have actually built an indigenous-led facility in Tallahena where folks are coming from all over the state and even out of state to have that experience of prenatal care or delivery. So there is work being done, and I'm meeting with Lieutenant Governor Flanagan here, who's spoken eloquently about her own experience as a Native woman trying to bring in some of those traditions. And when she had her kid about 10-ish years ago, not having the reception that you would expect, and the cultural respect for those traditions that you would expect, which in no way conflict with whether or not you're getting an epidural or whether or not you're doing a C-section, but just having that basic humility and respect to understand that for this patient, this is equally, if not more important, for something as meaningful in life as birth or death. And I think for
Yeah.
me, when I was going through med school, it really shocked me the extent to which they kept a lot of that at arm's length. And of course, it's starting to change with doulas, with midwives, with cultural traditions. But I'm curious to hear in your work with Native communities, have you seen some reincorporation of those beautiful, historic, cultural, and medical traditions into the care that we're seeing delivered in like within the four walls?
Yeah, I mean, it's our work with tribal health. We've been at this not super long. I mean, it's been a few years since this became a bigger focus for our organization. And last year, I had the opportunity to go on site alongside the chairman of our board, Admiral Wiaki, who was the 10th director for the Indian Health Service. And when he was talking to us about joining our board, one of the first, not a hard request, but he said, you need to come to Phoenix. You need to come to the Phoenix area because it's one of the areas of the country where you can see an Indian Health Service location, you can see an urban Indian health organization, you can see a tribe operated health center. So I had a chance to go last year, and it was transformational. And just stepping into the space, in particular the River People Health Center,
Mhm.
and the ways that they've brought in, I mean, even for the Indian Health Service and the hospital that they have, they have a sweat lodge in the back at the River People Health Center. They have an area where they do smudging ceremonies. So they've brought in and the cooking classes as well. I mean, it's an incredible way that they're blending the culture into the care and the kind of traditional medicine, and their traditional medicine and customs being brought into the healthcare organization and blending those two together to best serve their community. And one of the other reasons I wanted to be on site, I'll share it with a group because now that I know this statistic, I share it with everybody. But one of the lowest life expectancy rates in the world is in the Salt River Pima Maricopa area, where the life expectancy rate is in the 50s. And I sent an email to somebody a few weeks ago that listened to on a podcast, and they were claiming that the lowest life expectancy in the U.S. was like somewhere else. And I was like, no, I need to send this email because this person has an audience and a lot of visibility, and this is a problem that everybody needs to know. Their life expectancy rate on that reservation is lower than most low and middle income countries. I mean, it's one of the lowest life expectancy rates in the world. And having that as a pocket in the United States should shame us as Americans. And so I continue to think of that and talk about that with others because, unfortunately, from a population, volume perspective, I think they're undercounted, right? And so when you look at statistics, a lot of other populations that have a larger volume of people represented, may have disparities too, but it's a segment of our population that I think needs, those disparities need more light on it, and people need to know about these things. And I continue to talk about them so that we can attract more and more work. Obviously, always in conjunction with these communities because all our work goes hand in hand. Uh, but just a problem that I think at least having awareness and understanding these problems is really critical for all of us.
Oh, for sure. Thank you for sharing that. I did not actually know that there was life expectancies in the 50s in any community here. That is shocking. And I did know about, like, I mean, if you go to basically any major city, like if you go to Detroit and you drive like from Detroit to Bloomfield Hills, Michigan, Bloomfield Hills life expectancy is in the 80s. And in downtown Detroit, it's in the 60s. So that disparity is shocking, right? Bloomfield Hills, predominantly white, very wealthy suburb. Detroit, where I'm going in 2 weeks, I don't need to tell anyone on this call some of the challenges clinically and socially that their populations face. not least of which has been letdowns from the system of care. But I think to your point, and actually, food as medicine is such an interesting area,
Mhm.
and that some of that reclamation to like get the diet that maybe your ancestral community might have been following, and resuscitating that, it ends up being the macros that are in line with a 20-gram carb diet. And we've done this a lot with, like, we work with the Somali community here in Minnesota, and they're typically following the Somali American diet, which is not healthy and leads to 10x rates of gestational diabetes and just a lot of challenges. Um, but to go to their community centers, to go to their mosques, and to listen and learn and understand why they're following that. It's a combination of cultural but also economic realities. And so a lot of the health plans have now actually invested in, realizing that food is more than just a social determinant. It is health, right? If you're a healthy
Mhm.
and you're having a pregnancy, which nearly half the population will, it's like, okay, let's keep people healthy. Let's take that proactive approach and making sure that they get the groceries and or prepared meals that align with their cultural background and values, but also are going to be in line with the macros that we know biologically are going to lead to a healthier outcome. I think that's what you're doing. That's what we're doing. That's what our FQ partners are doing. And I think that's the future of medicine, because these sort of imperious, top-down, patriarchal approach. I mean, it kind of worked in oncology. You get the chemotherapy. My mom had chemo in the 90s. She was a breast cancer survivor. I remember, like, kind of what she went through.
Mm.
Nobody was there with her, right? It was just like, come in for your chemo, and then she's vomiting into the flower bed, and right outside, and it's just it kind of shocked me into like how inhumane in some ways the practice of medicine was. But yeah, thankfully we had those drugs, and they cured her. And this is before Gleevec and all that. So this was like very harsh chemotherapy. And so I think in some fields, yeah, okay, like an infectious disease, the antibiotics kind of got it. But how do you get people in a space like chronic disease, in a space like pregnancy, to really trust you, and every day when they wake up do the thing that you want them to do? You cannot detach that from their reality. And when you do, you end up with situations like what you were sharing in Arizona, or what I was talking about in Detroit, where like you have clinicians that don't look like you and don't understand you and don't even make an attempt to understand you. You're not going to go home and follow their low salt diet and take your furosemide Lasix, and and then you show up in the ED 2 days later with decompensating heart failure. So that was the paradox of medicine that really struck me when I it's not really what I expected when I came into the field, because it doesn't make rational sense. We should be investing in community health workers, in the people who can actually help these folks follow the diets, take their pills, and we don't do that, and then we just end up seeing them repeatedly in the ED. So I think what Care Message did is it shows that when you can reach the patient, you cross that bridge, right? You're able to get when they're feeling alone. And I think with Delfina, we've expanded on that principle, where like our doulas, you don't have to have the doula there holding your hand 24/7 to feel connected to her. You can call her at 10 p.m. and you can have a 3-hour call if you experienced a loss previously and you're having anxiety, or you can have a 6-minute phone call or a text like, "Hey, I lost my BP cup. Why do I have to do this again?" And the magic of that connection is that when you come from the same background and so people often ask us, like, we hire doulas from the same communities. We've hired a lot of doulas from Houston. We've hired doulas from Austin, from Houston Tillotson University, a historically Black university. Now, these doulas, when they practice with Delfina, are basically entirely practicing virtually on a screen with the
Mm.
patient on the phone, or texting with the patient. So, like, how do you see this effect with doulas, where doulas are driving the lower incidence of preterm delivery? That's what's all over our website and our publications. Doulas are a major, major part of that, which has led us to double down on them. And people are sometimes in disbelief that, like, how can you do that over a Zoom? Well, that's because the Zooms that you and I have, Cecilia, are like me in a suit talking about healthcare. When they're coming from a shared cultural background, they're talking about the same cultural institutions, the same bodega down the street. And so they have the same cultural touchstones that really help drive care and drive adherence, and continue to build trust day after day through that pregnancy and postpartum.
Yeah, that cultural connection is critical, and I'm going to put in a plug here because we do have a session later today on reclaiming indigenous food. So we do have that session later today for everyone. Hopefully, stick around. Going back to that, kind of that earlier point, which is critical, the cultural connection, and almost bringing that back can be very transformational for how patients can be receptive to their care, to the care plan, and that connection is just so critical. And I'm curious if you can share maybe what has been maybe one of the you shared a lot about your work with doulas and that investment into that part of the workforce. What are other maybe areas of care that you're most excited to continue to invest in, and like how that's changing the outcomes for patients?
Nutrition and metabolic health. I'm excited for that session later today, and I think food is medicine. In medical school, I had two lectures, two 1 hour lectures on nutrition, period, in 4 years,
Mm.
and that is shocking to me, just given how much. And I think now, probably things have changed, but this was 10 years ago, and I think and even at that time, I was interested in nutrition. I knew about macros, but I was like, how are people graduating med school and barely understanding, and much less knowing the science and the biochemistry, but the clinical context and the cultural context in which people are consuming food, food deserts, culturally competent diets, adaptive diets. We just weren't even learning about that. And so I think now, we're in a very interesting time where GLP-1s have transformed obesity medicine, and they are still inaccessible to a lot of the Medicaid covered population that we work with. And I don't believe clinically that they're going to be the ultimate full solution. I mean, you have sarcopenia, you have a lot of clinical issues when you are on a GLP-1 for life, and you can never come off of it. So I think they're a very valuable tool in the arsenal of trying to get folks to a better BMI, or especially jump-starting metabolism. But I'm very excited in pregnancy care in particular, where gestational diabetes rates have been skyrocketing. Even when we started Delfina, the gestational diabetes rates were closer to 10%. Now they're closer to 20%. And the average age of a pregnancy in Delfina went up from about 25 to 29. We're in a majority Medicaid population. In the US, it's gone from about 30 to 32. So with more advanced maternal age, more use of fertility services, which is awesome that it's becoming more accessible, more and more people using it, that itself is a risk factor for gestational diabetes. So I think given
Mm.
how we have three main verticals in Delfina care. There's the hypertensive, there's the gestational diabetes, metabolic, and there's the mental health. I think of hypertension as okay, in our first chapter, we have a slam dunk there. We brought down the incidence demonstrably of hypertensive disorders of pregnancy, preeclampsia, preterm secondary to preeclampsia by 20+%. We're going to keep doing what we're doing, and until there's a curative therapy for preeclampsia, we're not going to be changing it too much. Metabolic
Mm.
health is kind of in this middle space where we have actually very good predictors. We can tell you 80+% of the time, Cecilia, before somebody has any weight gain, who's going to have excessive gestational weight gain. We're going to tell you who has gestational diabetes. But the what do we do about it part is the real question on both the diet and the exercise side. You can't take GLP-1s in pregnancy. You can't, and a lot of the sort of general medical interventions for obesity and or metabolic health are just not applicable. And you're not going to put them on insulin or metformin until they have a diagnosis of gestational diabetes. So in the intervening three, we just gave everybody for okay, we know it's going to happen. What do we do to mitigate it? So we worked with Mayo Clinic on the exercise side to really codify and come up with a program based on the evidence. How do we get that working? Diet I think is much more interesting and dynamic and culturally relevant because
Mhm.
people are having dinner with their families. These moms are usually preparing dinner for their families and their kids while they're going to eat the same thing themselves. So I'm really interested to see and to work on in the next few years with partners, how can we come up with not the individual diets, but a dietary nutritional paradigm for pregnant patients that really maximizes the likelihood that we help them, have a healthy baby, not have gestational diabetes, not have a macrosomic baby, not have shoulder dystocia. The consequences, that's the interesting bridge to me, where it's something as simple as what you eat that night, but it is very, very closely related to whether or not you might have some major challenges for yourself or your baby 6 months from now. So the patient motivation and understanding and education part is also really fascinating to me, and I'd love to hear more and look forward to the session today on metabolic health.
Yeah. And I know we've got a few minutes left, and there may be some questions in the chat, but one last question for you that I definitely wanted to close up with, at least on my end. What has been one of your most proud moments at Delphina?
I'd say my proudest moment was actually when I heard about this other patient who had on her phone, so Delphina has a network, right? We have 160 clinics that are on Delphina and have that dashboard. Majority of clinics in the US and even Texas, which is our biggest state, are still not on Delphina. Majority of hospitals have never, what's a Delphina? And so a year ago, we had a patient it was a hot day in Houston, it was last summer. And so she started feeling lightheaded and she was I should probably go in. So her husband takes her into a random ED. They weren't even in their home part of Houston. So it was just some random hospital, community hospital. And the ED docs there start like freaking out because her vitals are really high, her blood pressure, her heart rate. They're like, oh, she's tachycardic, she's hemodynamically unstable, and they start talking about doing a C-section and like paging OB, like
Mm.
consult, see if we need to do a C-section. And her and her husband were both like, C-section, like what, like why? And then she was like, I think my her husband actually was like, hey, don't she was like, don't you record all of your vitals on that Delfina thing? And then he hands her her phone. She pulls it up on her phone, smaller than my phone, and she's like zooming in like this and showing them the traces of her heart rate, of her blood pressure at baseline. So in this case, it was no fancy AI connecting to the provider. It was just empowering that patient that she was like, look, this I'm usually around 100, 120 anyway. That's my baseline, and that's okay. That's healthy for me. So that brought the temperature way down. They still consulted OB. OB was like, you're fine. Let's just put an IV saline and send her home. And that mom delivered a healthy baby at term according to plan, 40 weeks, no complications. So we're so proud of that story because it just shows the empowerment of the patient and the family and what that can do for the maternal health crisis.
Amazing. Well, we've got a minute. I don't know if there's, sorry, I'm just going to check the chat here. And if we might have time maybe for one question. There's a question from Anu on what are the lessons learned that were incorporated when some of the experiences were not a norm managing and monitoring pregnancy during the gestational period?
I'd say the number one lesson was really understanding the patient psychology. Like we had a patient who I met like while shadowing, and the doctor was like, "You have to meet her. She's like exactly who I want on Delfina, and she hasn't really been using it." So I was like, okay, ma'am, like, what is it about Delfina? She just like shows me her phone, and she only spends 20 minutes a day on her phone. I almost couldn't believe it. But she has a toddler.
Hmm.
She's in school, and she was like, on my first pregnancy, I was spending like 8 hours a day on my phone. I was like, okay, in your first pregnancy, what do you do? She was like, still, honestly, I don't know. I was like, why not? And she's like, well, it's kind of boring. Like, this dull, like clinical apps. Like, I don't, she's 23, 24. She's like, she was like, you are on this boring side of my phone with like my PG&E and whatever. Like you need to be on the fun side of my phone with Instagram and TikTok. And so we really took that to heart that like for most pregnant patients, they're not even thinking about pregnancy necessarily clinically. It's personally, it's for them and their family. And so we created a social experience. 25% of our patients actually invite a pregnancy buddy, family member or friend. We knew we had to do that when Abuela was trying to download the app and be like, hey, how do I support my granddaughter? And we're like, okay, if she's doing that, we got to build something for her. So it's usually a mom, a partner, or a sister. But yeah, that makes folks even more engaged. And the patients are using it every single day. Their doulas don't even need to be the ones reminding them. Usually, it's like their sisters, like, "Hey, did you take your aspirin today?" So I'd say that was a big unlock. That just really understanding the patient psychology and what motivates them and how they think about their pregnancy. It's very different from how we sit there in the room and do our clinical workflows, but it's the patient's lived reality that we have to meet them there to actually effectuate the outcomes.
Yeah. Well, we're gonna wrap up here because I know they're moving on to the next session, but this has been incredible. Thank you so much for joining us today and sharing your story and the story of Delfina. And if any of our health centers that are here today are interested in connecting with them, let us know. We'll make sure to make an introduction. But thank you so much, and looking forward to keeping the conversation going.
Thank you so much for having me, Cecilia, and thank you so much, everyone, for listening. Look forward to engaging further.